It's going to be a repetition. I thought I'll just add a few twists to how we set up our program in Chennai in India. I think the robotic program here is up and running, and I think you may get a few points, I might learn a few things, but I'll just run through how we started. We only started a few years ago. So for all the young surgeons here, it's all achievable, and you could be up and running very soon. So it's very important to understand that TME of the rectum technically is challenging, and similarly setting up a robotic program as well. So the important aspects of these are training and skill sets, technology. Again, technology is widely available. If you can afford it, you buy the machine. But then volume is important. To do, say, 30 rectums in a year or 40, 50 rectums in a year is very important, because then your learning curve is quicker and your skill set improves. And again, the cost, it may not be very relevant in different parts of the world, but in where I come from, it's very relevant to, keep it, as low as possible. And it's also important to engage and collaborate with the peer group. And that's how we set up successful programs. And if you set up a successful program, particularly in case of, like, say, the rectal resections, I think you'll have good outcomes. So training and skill sets. So what I got trained in the UK. I undergraduate in India and went to the UK. I'd spent 15 years going through the full training. And I moved back to Chennai in 2011-12 and joined this hospital in 13. So we set up a lab program. People, again, were a lot of general surgeons, oncologists who did everything, and they're very good at it. But again, the complexity of dealing with rectal cancer or colorectal disease is changing. There's more technology available, skill sets, and precision, and particularly in TME. I think it's very important. I think to just do 1 or 2 cases a year doesn't really help. You need to do it consistently, regularly, and in good volumes to get the best outcomes. So we set up the lab program in 2013. Lab was offered as default technique to all comers. So between 2013 and 15, we did about 103 procedures. And then that's when I met Emre. Emre had come to, as part of the Da Vinci intuitive training program, come to India. And the urologists in the hospital were already doing amazing number of urological procedures. So for colorectal, he was coming across the country and training people. So I met him in Chennai in 2015, and he was brilliant. And he just made it simple. We went through a few cases, and that's how we were swapped over at that point in time, 2015, to robotics. So I came to the States. I went to the States, rather, to Atlanta, to the 2-day program on how to use a robot and things like that, and then went back and swapped from lab to robotic. So I didn't go through a formal robotic training program, but I had lab training program in the UK. So, and I did about 100 cases laparoscopic before I moved on, and I had robotic urologists in the hospital who helped us to sort of get through that initial phase of doing it all alone. So, looking at our program, so we sort of look at now if people want to come and start doing colorectal work, we looking at least experience of performing at least 50 lab colorectal procedures, evidence of completion of the intuitive surgical robotic training course. And now again, just touching on the lab, I know a lot of papers it says you can adopt to robotics very quickly, but I think having laparoscopic experience is very important to learning to know how to work inside the abdomen 3-dimensionally. Triangulation, all those are very important, and it's much easier with the robot, but I think having that experience really helps. And then we have an observation of at least 5 cases, and then a proctor is being present, and then and then the next 5 cases, the surgeon is scrubbed in but not doing a procedure, and then we audit the cases, and then and then the surgeon can start doing it. So, but I think one of the most important components of a successful program, particularly when you're dealing with rectal cancer, is to have a good multidisciplinary team. And I think we had it very ad hoc, and a year and a half ago we set up a dedicated MDT every Friday morning, 8 to 9 o'clock. We go through all the cases which come through the department, cases which are coming in, cases have been operated, and on average now we've done about a year and a half. We have about 12 people attending, and that's a big achievement, because once you set up these programs, it's coming in the morning 8 to 9. You have work scheduled in, pathologists, radiologists, physician assistants, tomotherapists. To get the group together is very important, whether it's in the morning or in the afternoon, but it's important to have the MDT because it really improves the outcome because you discuss every case, you make a joint decision, and you decide on which approach, maybe an advanced tumor, you want to do it open or minimal invasive. But and you also, each member of the team has got a dedicated role, and I think it's very important to get this group together for any successful program, particularly if you're going to deal with rectal cancer. And we also developed a two-team approach, and we have a console team, that is the main surgeon, whoever it is, and he's responsible for the entire robotic dissection right up to where you're transecting the colon, rectum or the colon, and the bedside team, which is who's the main assistant, trainees are there, the scrub nurse, and they are responsible for patient position, port placement, extra retraction, stapling, specimen extract, and anastomosis. I think it's very important to have these two teams because it becomes super efficient. You have clearly defined roles, and I think significant benefits of your operative time comes down, your complications come down, and the people are really clued in. And I think the next step is where standardization of technique. So, when I started doing these things, I used to take the vessels. And then I used to, go and do a bit of TME, transect the bowel, do the right side, left side. And we were taking 4 to 5 hours. And in 2015, I went to see my old friend Amjad Parvez. I don't know if any of you know him. He's a professor of colorectal surgery at Portsmouth. And he had a technique of which I will show you basically. I went and, it was 2006, a few years ago, and adopted his technique, and I just shaved off an hour and a half of the operative time. I think so. The point I'm trying to make is very important to attend these meetings, speak to your colleagues, senior colleagues, go visit centers like the Cleveland Clinic, and to see what they do, because every time you go and see, they'll have little things which will improve your outcomes, and I think it's very important, or the time, speed, avoiding complications. I think very important, keep that as a continuous process, however senior you are. So as for TMEs, we have standard bowel prep, for TME rectal procedures, epidural GA, and Ryle's tube, primarily because sometimes the stomach's all bloated and swollen with gas, so the Ryle's tube helps to get the gas out, and catheter and a steep head down roll towards us. So this is an SI port placement. So typically, again, I only use 3 arms, one for the camera, and the left arm is for a bipolar grasper, and the right arm is for a monopolar scissors. And there is a 5 millimeter port on the left iliac fossa. For retraction on the right iliac fossa, we have a 12 millimeter port for staplers and swabs. And the person is sleep head down roll towards us. And for the X side, slightly more or less similar, but again, you don't have to worry too much about the X side, because even if it's not exactly placed the ports, you'll be okay. But essentially, 3 ports and 2 assist arms. So the procedure steps are ligation of the vessels, medial to lateral dissection, splenic flexure takedown, if required, and TME. So I think we've already seen this video. It's the same again, so I'm not going to run through that. So once we start to come into the push, so we finish the vessels, we identify the ureter and the gonadals. We've seen that in the last video. Now we just enter the TME plane. So the big difference you'd see is you get a stable platform on the robot, okay? So, your camera control is under you, and you use your joysticks to zoom in, zoom out, to see how close you are, or you want to go back. It's all under your control, so you're not depending on the assistant to show you. And it's very stable. It doesn't fog as much because there are 2 chips at the end of the, the camera for the robot, so it doesn't fog as much as laparoscopy. And the trick is traction. Your left arm is, behind the mesorectum, lifting up, as you can't see it, but that's what it's doing. And then you stay close. So I'm just going to run the video. So you can see it's such a stable platform.
Can you show us the nerves?
So yeah.
Can we see?
So the nerves are just there, and it's important to see these angel fibers, angel hair fibers, which are like nice, flimsy, white fibers. And I think that's the secret for TME. Once you know how to do it, time on, time again, you would. So you could see that just the gentle traction, it will show you the plane where you need to be. Get close, just stick to it. Stay close to the rectum. Try avoiding going there. You just need to be right there, and use the tip of the. instrument as a paintbrush, and I think it's very important. So left arm is the secret. I keep telling you again and again, because it's one thing which you want to do. You need to start doing robotics, is to use your left arm very effectively, and I think it's absolutely makes your operations so much easier. So you can see my left arm is still going in, and I'm opening my instrument, just giving that traction, lifting it up. So step 1 was vessel. Step 2 is posterior dissection right up to the pelvic floor, as far as you can go. And you always have to remember that the pelvis curves. So you don't want to go dissecting and hit the you don't want to go and okay. So once we've done that, then we start with the anterior dissection and the right lateral and the anterior dissection. So if it's a female and if you think the uterus is flopping around, what I do is I use a straight needle to sort of go, hike the uterus up. I think it's very useful. If it's a male, once you cut the peritoneum anteriorly, you can again hike the peritoneum up so that you open up that space nicely. And this is so anterior dissection. You can see the important thing to remember is that the fat stays with the rectum. I think once you get confused where you are, you need to make sure that this fat stays with the rectum. If you can see the rectal wall clearly, then you're one layer down, and I think that's very important to maintain that. So again, left arm is giving enough traction, identifying those nice angel fibers, just makes the operation so much easier. And you can just see here the the pelvic floor muscles starting to come. So again, you've done the left side now. So posterior, right, anterior, and then you finish the left. And then you can see the fibers of the pelvic floor starting to come up nicely. And you can see the muscles there. And you stop, So this is with an SI, where suppose you want to look down or up, you need to take the camera out and then turn it around and put it in. With the XI, you can flip it yourself in the console. So I'll show you that later. So this is literally almost now getting into the intersphincteric plane there. You can see such stable views, and it could be quite challenging to get the similar views in laparoscopy, and I think that's where the robot is very useful. So you're right in the intersphincteric plane there. So that's a standard TME which you would do, and I'm just going to look at our volume. So it helps to be subspecialized, have an organ-specific approach, and I think that increases the number of patients you see and the volume you go through. So we've seen that in our, it's about number of cancers we treat slowly has gone up. The robotic procedures have also gone up year on year. And so our robotic experience is that we've done about 182 cases, and most of them, majority of what comes to our practice is rectal cancer. And we do a bit of colons and for pan-proct and then some rectal prolapse work. So quality monitors wise, that our nodal harvest, as I was telling, between 12.5%. We have a 2 to 3% leak rate. Our resection margins are acceptable, and an A loss is around, 4 to 5 days or 5.5 days roughly. So we've seen that these are subset analysis. We've seen that, as your experience increases, your operative time, console time comes down. That's what we've seen consistently, and your resection completeness of the TME specimen also improves with time. Looking at costs, I think with more experienced two-team approach, and we use 2 arms primarily because of a cost issue, but again, and we use a lot of reusable ports, and in increased volume reduces the operative time and less complications. And we've seen that our cost for laparoscopy and robotic almost coming together. So, that argument again, like laparoscopy won't be relevant in due course. So I think with training, subspecialization, case volume, your lap experience adds in, you're increasing robotic volumes and refinement of your technique. It's so important to keep that going. And, and it results in reduced OR times and costs, and ultimately gives you, the patient, the best outcomes. And it's also important, like this meeting, we have a strong collaboration with the Cleveland Clinic, Florida, and now with our colleagues in Ohio as well and UCL to have teaching and training programs, analyze our data, we write papers together. We've started our symposium. We did our second symposium earlier this year, and hopefully we'll get the teams from here to participate next year. And we have a very active community on Twitter, and I encourage all of you to hashtag colorectal surgery or colorectal research on Twitter, because you get the top 15, 20, 30 colorectal surgeons in the world actively engaged on a day-to-day basis, and you can talk to them, ask them questions, and it's a brilliant way of communicating. There's lots of question answers, surveys going on, and I think it's very, very important. You learn everything. You say operating room, between cases, you just go through your Twitter account and you see relevant questions, cases, or had a complication, how do you deal with it? And I think it's social media is playing a major, particularly the colorectal community. They use it very well, so I suggest that if you guys want to be interested, and I encourage you to sign up to that. And you could see Emery there, and I visited the Ohio team. But it's important to develop relationships. It's very important, because I find that that really helped improve our outcomes in the long term. So we're part of other training programs, and I hope the teams here also will get involved in these things. And this is our most recent meeting. We had Emery talk, give several keynotes on it. And I think subspecialization drives skill set, expertise, and volume. More volumes, better outcomes, particularly in rectal cancer, is very important. And I think you try to innovate. You use, whatever is available. You try to innovate on cost, technique, and I think it's very important to keep that going. And engaging with peer groups is very useful for your practice. Thank you.